Hi, everyone. My name is Dr. Leanna Selden, and I'm joined by,
Erica said,
and we are here to talk about lymphedema. So, I'm going to explain the clinical causes of lymphedema and what lymphedema is, and Erica will talk about the treatments out there. So, lymphedema is basically a progressive condition caused by impaired lymphatic flow, and it causes an accumulation of protein rich fluid in the extremities. And this results in inflammation, adipose deposition, and eventual fibrosis if left untreated. And this condition affects millions worldwide. But in the United States, the most common form of lymphedema is what we call secondary lymphedema, and it's most commonly after cancer treatment. So there are basically two types of lymphedema out there. There's a primary lymphedema, which is the rarer kind, and that's the lymphedema that's congenital or genetic. Some two examples include Milroy disease and Mage disease. And the secondary is after a malignancy or a lymph node dissection, radiation therapy, infection, chronic venous insufficiency, and trauma. And under trauma, I'm also going to include surgery. So in clinical practice, this is what we mostly see. And the pathophysiology is basically that there is insufficiency in the lymphatic flow of fluid against gravity. And therefore, fluid is not brought back up either because the lymphatic vessels are just not working properly or there's just way too much fluid in a normally functioning lymphatic system. So what happens is you have this accumulation of protein-rich lymphatic fluid, and that causes the body to go into a chronic inflammation mode. And then over time, when there's so much inflammation, this can convert into adipose or fatty tissue. And then over time, that can also convert into fibrotic, more hard tissue. Um, and this is why it's so important to treat this early. We don't want to see somebody whose um, extremity is overtaken by adipose or fibrotic tissue, because at that point, the swelling just becomes a lot more difficult to manage. So when somebody first starts with lymphedema, it's very hard to diagnose because the symptoms are very nonspecific. So the patient might say they feel very heavy or tired in their legs or tightness. They might have some mild swelling that can resolve with elevation, but there are multiple other conditions that can also produce swelling that resolves with elevation. But later, the condition then just becomes more persistent, and the actual skin will thicken, and you can even see hyperkeratoses on the skin, and you can see these little nodules on the skin in later stages. Now, how do we stage this? So the first stage, it's stage 0, which is subclinical, where you don't see visible swelling, but there is some pathology in the lymphatic flow. Stage 1, you start seeing some pitting edema, which resolves with elevation. Stage 2, you're seeing the non-pitting edema, and it's not fully reversible because now the skin is, or the tissues are being overtaken by fatty tissue and some fibrotic tissue. Stage 3, you get that elephantiasis and you see more fibrotic tissue and more skin changes. And then stage 4 is a more advanced presentation of stage 3. So the more we can catch at stage 1 or even stage 2, the better it's going to be for the patient.
with that being said, I want to jump in and ask you something here because you mentioned stage one with pitting edema and reversible elevation. Um, Oftentimes, patients are told, you just had too much sodium. Just go home, lift your feet up at the end of the day. And they see a little bit of a difference and they think, oh, that's all it was. And how often are patients so um, underdiagnosed because they have that thought process that I just had too much salt today.
Right. And then so the difference is this just so they adjust their diet. They'll have a low sodium diet, but they'll still have the edema.
Mhm.
Um, And also, it's important to keep following up with them because you might see them 6 months later with the same problem unresolved.
Mhm.
Yeah. But to that point, there are other conditions that also can cause this swelling.
Mhm.
So, something we often see in the office is chronic venous insufficiency. Now, one of the differences between chronic venous insufficiency and lymphedema is with chronic venous insufficiency, you're oftentimes going to see varicose veins. You're going to see what's called hemosiderin deposition, where the skin is mottled or there's color changes in the skin, and you don't necessarily see that with lymphedema.
Mhm.
Also, with chronic venous insufficiency, you will see most of the swelling in the leg, whereas in the later stages of lymphedema, you're going to see the actual top of the foot being swollen.
Mm.
And there's another condition that is a differential diagnosis when you see swelling, which is lipedema. So, lipedema is where there's just fatty deposition instead of liquid deposition in the extremities. But lipedema can also progress with in conjunction with lymphedema.
I was just gonna say, oftentimes they come
They
together.
come together. Lipedema, you see that fatty deposition in the leg, but not so much on the foot.
Mm.
But there are subtleties that we have to recognize in making the diagnosis. And another cause of swelling in the legs is heart failure or CHF, but that's that pitting edema, bilateral lymphedema, and and even chronic venous insufficiency can be just one leg.
Okay.
So when you talk about systemic causes such as the CHF that I just mentioned or renal or hepatic disease, it's bilateral, it's both extremities. Um, and then the other differential diagnosis, which is extremely important to rule out, is the deep vein thrombosis, because that is also something that we see on one extremity and not two. And if untreated, obviously can be fatal. So it's very important to get, to take time with the patient, get a good history, and get a good physical exam.
Right.
So with lymphedema, as I mentioned, it's very clinical. It's diagnostic tools are not as widely used as it is to differentiate with other conditions. So one thing that I just mentioned, which is the deep vein thrombosis, if you see that unilateral edema, you see only one leg, it's extremely important to order a venous Doppler
Mhm.
to make sure that it is not a deep vein thrombosis. Laboratory exams, um, or referral back to the primary or cardiologist to differentiate between the systemic causes, such as heart failure or renal or hepatic issues, is important. Um, Now, you can also measure limb circumference and take volume measurements. Um, and there's also lymphoscintigraphy, which is the gold standard for conforming lymphatic dysfunction.
I've never been able to say that.
I know. Yeah. I'm also having a hard time saying that too. And other imaging, such as MRI, can be of use, especially if you suspect that there's a space occupying mass that's preventing the lymphatic flow. That can be, diagnosed with MRI. And there's also near infrared fluorescence that can be used in specialized settings.
Are those studies something that the patient can advocate for themselves if they have the idea that they may be suffering from these symptoms, or is that something that they have to first go through a sort of treatment prior to being ordered that study?
I mean, yes and no. If there's long-standing, for example, if they've gone to see multiple providers and all have said just elevate your legs and the
Mhm.
patient's not gotten any relief or improvement of their symptoms, sure. I mean, it's important for us to get a full picture.
Mhm.
It is not, the standard of care to order advanced imaging on first presentation if, say, somebody's had symptoms of swelling for a day, but especially in light of if there's only one extremity and we're not ordering a Doppler exam, one extremity affected and we're not ordering a Doppler exam, that would be a great disservice to the patient.
Okay.
Um, but yeah, if, to your point, if it's been a long-standing unresolving issue, yes, the patient should speak up for
Okay.
sure.
So, with a patient that has been having issues, history of chronic swelling, and they present to their physician and they say, "Look, I've just been dealing with this for so long," is that something that the physician can feel comfortable subjectively reviewing chronic history of illness and talking about their symptoms to just say, "I feel comfortable diagnosing you with lymphedema or otherwise,"
If
prior to studies, or is that something that
Yes,
okay.
yes, because, if you've ruled out all the other potential, etiologies of the swelling,
Mhm.
absolutely.
Great.
Lymphedema does not require imaging in and of itself for that diagnosis. It's a clinical scenario that we're looking at to make the
And
proper
that's really
diagnosis.
important for providers, I think, to hear. So I'm so glad that
Yeah,
you have that experience to say that.
yeah,
Absolutely.
yeah. So what are the potential complications of not treating lymphedema? So number one is going to be cellulitis or infection. So, the skin is an organ and its purpose is to protect us against microbes entering our system. So if the skin is being stretched to its full capacity because it is overwhelmed with fluid, um, then there's an increased risk of loss of integrity of the skin surface, and bacteria, fungal organisms, other microorganisms can enter. And also, if the fluid is backed up, if you have a stasis of fluid in the extremity without motion, that also can house microorganisms and produce a cellulitis.
What a great way to put that. I've never heard someone explain the skin in that manner, and that makes so much sense. And it's actually very informative when you think about it. I've never thought about the skin being just a protective barrier to the rest of us.
Yeah,
And
that's what it's
wow,
there for. Yeah.
that's a really great look on that. I'm gonna take that with me.
Please do. Okay.
Absolutely.
Um, and then another, so that would be cellulitis being infection of the superficial tissue, but then you can also have inflammation or infection, lymphangitis of the deeper of the lymphatic vessels themselves,
Wow.
without the proper treatment of lymphedema. You can also have functional impairment because imagine you're carrying pounds of fluid where it shouldn't be.
Mhm.
So that prevents a patient from wanting to get up and walk because it's just so uncomfortable. And also, you can have leakage of fluid. So if you're not compressing and bringing that fluid back up, and there's a break in the integrity of the skin, patients will often develop bulla or pockets of fluid that can burst, and further risk them for infection
Wow.
of the skin structure. And then obviously this is going to cause a psychosocial, impact.
Sure.
So, for that reason, the earlier we intervene, the better for the patient.
100%.
So speaking of intervention, the mainstay of treatment is actually conservative treatment, and that is compression therapy. So when we first see a patient, let's say they have a severe case of lymphedema, um, one treatment option would be referral for lymphatic massage to help get that fluid away from the extremity, back to where it should be. Also, us as podiatrists can put on compression dressings. The first one that I think of all the time because I use it very often in my office is a visco paste or an Uniboot.
Mm.
And the other one would be, there are some systems out there that are 2, 3, 4 layers where all of them are elastic type dressings. So that is used sort of as first line therapy as part of what's called complete decongestive therapy or CDT, where we are trying to get all that fluid up and trying to maintain, or bring that extremity back to its ideal circumference in order to prepare the patient for maintenance therapy.
It's interesting because I bet you didn't know this, but I'm actually a licensed massage therapist.
Oh, I didn't know that.
And I have seen with my own two eyes the effects of manual massage and drainage, lymphatic drainage on patients. Both with lymphedema and without. Just the fact that when you start paying attention to that part of your body and you're making those efforts,
Mhm.
it can really make a difference. You start to see it drastically.
Yeah.
So to have the complete decongestive therapy as a whole be understood by the patient population is also very important. So I'm so glad you brought that up.
Yeah. Yeah. So compression, whether it's done manually by a therapist or a wrap or a garment that the patient wears, is the mainstay of treatment.
Mhm.
Unfortunately, there isn't a cure for lymphedema. Lymphedema is a chronic condition, but it's something that me as a practitioner, there's a role I play, but it's so important that the patient maintains that long-term therapy. Otherwise, if that therapy is interrupted, we're back to square one.
Mhm.
Um, and, you know, in conjunction with the compression therapy, once we can get that edema somewhat better controlled, that allows the patient to do some exercise. And exercise will also help
Mhm.
because it's that muscle pump action that will help bring fluid back up, just like it does with venous stasis.
Mhm.
But it can also help with lymphedema. And some forms of exercise can include walking, swimming, or just resistance training. That's a great adjunct treatment that the patient can do on their own. Um, and also just good skincare.
Mm.
So, especially for us in the office, putting on these serial compression wraps when we're seeing patients in the initial phases of lymphedema treatment. It is important to keep good skin hygiene. I tell my medical assistants all the time that once we remove the dressings, to just really make sure we clean the patient's skin properly, because they're not going to have access to cleaning their skin for a while.
Right.
And also putting on moisturizer, keeping the skin in good condition. Um, Looking out for abrasions, looking out for any wounds, nipping it in the bud before it becomes a chronic situation is
Right.
also important. Um, and, you know, um, just trying to recognize the early onset of cellulitis if that occurs. Um,
I'm sure it's a big one. I'm sure you see it often where patients have just kind of said, I put it out of sight, out of mind, and they prefer not to even look. They prefer not to, inquire within themselves to see how things are doing until it gets so bad that they have to come see you. And you're like, how did this get to this point?
yeah.
I can imagine. So that's key is just being aware, staying on top of it, being mindful, like you said.
And it's also difficult when something's constantly covered.
That's true too. That's
Yeah.
true too. And then it's half the hassle of having to take the garment off and seeing yourself. So I think you make a good point is also to make sure you're checking in with yourself.
Yeah. And
Yeah.
having some kind of support, some kind of family member,
True.
spouse,
True
it's
too.
not available for everybody, but that certainly helps.
Absolutely.
Yeah. Now, I spoke about some conservative treatment, and you're going to speak more about, the types of compressions out there, but it's not very commonly done, but there are some surgical intervention that can be done. There is such a thing as a lymphovenous bypass.
Wow.
There's vascularized lymph node transfers, and there are debulking procedures that can also provide some relief. But again, nothing will absolutely cure this. This is a chronic condition, unfortunately. Um, and so, you know, the key takeaway is early intervention, as with most disease processes we see, is important in preventing long-term complications. If we start compression and compliance on the part of the patient sooner rather than later, it becomes so much easier to manage. And speaking of easy to manage, there are, when I first started practicing, the only option out there were, very heavy compression stockings that many patients, especially elderly patients or patients with orthopedic issues, would find impossible for them to to apply. So luckily, we live in an age where there's more options out there for patients to be able to continue the treatment.
Yeah, you make a great point. My grandma can't even open the cap of her own water bottle. So I
Yeah.
can't imagine having to lift up, really super stretchy garments on their own. So
Yeah.
100%, you make a great point for that. Thank you, Dr. Selden. That was an excellent clinical overview. And it really highlights the important points. Identifying lymphedema is only part of the equation. The real challenge is what happens after, and that's where we tend to see the biggest gaps. Where we consistently see breakdown is not in diagnosis, but in access, follow through, and long term consistency with treatment. And that's something that affects both patients and providers. For patients, it can feel overwhelming understanding what's covered, what to do next, and how to manage something that's ongoing. And for providers like you, it's making sure that what's being recommended actually turns into something the patient can realistically follow through with. Historically, we see a consistent breakdown in follow through with long term treatment. A patient is identified, compression is recommended, but then it stops there. Maybe it's cost, maybe it's confusion, maybe it's just that life gets in the way. So there's this gap between recognizing the condition and then actually managing it, and not to the fault of the physician or the provider or even sometimes the patient. But this is where the Lymphedema Treatment Act, or more commonly referred to as the LTA, has made a meaningful difference. As of 2024, Medicare and many other insurance plans now cover compression garments used to treat lymphedema and other qualifying conditions. And what that means is, in practical terms, that patients now have a clearer pathway to actually receive the treatment they need. And the conversation is especially timely since March was Lymphedema Awareness Month. And the goal of that initiative is exactly this: bringing more awareness to the condition that's often underrecognized, like you said, and making sure both patients and providers understand there are real accessible treatment options available. Through the LTA, the patients now qualify for up to 3 garments per affected body part every 6 months. Those are daytime garments at that. They are also eligible for nighttime garments. So they're really making a point to make treatment accessible and something they can use. There's a reason that they've given them the 3 garments per affected body part, and that's so that they can really be consistent with it. Something as simple as having multiple garments to rotate make a huge difference. It makes it more realistic for patients to stay on track. So when you have that wear one, wash one, dry one, it removes that "I can't wear it today" barrier.
One thing I do wanna say, so when we talked about the different stages of the disease, so the earlier stages is reducible by elevation. So when we get to the later stages of the disease, that swelling doesn't go down ever, and so it's important to have that nighttime compression as well.
Ooh, okay. That's a great fact.
Because sometimes, especially when we talk about venous stasis as opposed to lymphedema, when a venous stasis patient elevates their leg, the swelling goes down. So when they're sleeping, they don't need a garment
Mm-hmm.
versus a lymphedema patient.
Ah, that cycle is still interrupted. There's nothing that being laying down or standing up is going to
Yeah,
change it.
gravity's not helping them. So
Gotcha. That makes a lot of sense. So, from your perspective, how often do you see patients struggling with consistency once they've left your office and you've said, okay, you need to be wearing these compression garments?
very often.
And that's the part that the consistency is what really drives the outcome. So, even with the best treatment plan, it doesn't work if the patients are not following your treatment plan day to day. So, when it comes to treatment, compression therapy, like you said, is the golden standard. But one of the biggest misconceptions is that it's one size fits all. And it's not. There are different types of compression, and each one plays a different role depending on the patient and the stage of their condition, as you know, because what we're really treating exists on a continuum. Patients can move between early, moderate, and more advanced stages depending on what's happening clinically, and compression needs to be adjusted accordingly. So, of course, appropriate assessment's important. Making sure, like you said, the vascular status is considered before initiating compression and that the approach is safe for the patient. But most commonly, compression garments like stockings or sleeves are the first line. And patients are deterred because, like you've mentioned, they're just not easy to put on. It's not something they can stick to on a daily basis, especially even on their own. So, there we've got the second type of compression garment available to them, which is the wrap. And I have found, from what I've seen from patients that have been utilizing the wraps, much more compliant. It's easier for them to put on, it's easier for them to manage, and it takes away that um, pause from going, am I going to stick with this or not? You know, and so I'm just really happy to have you here because, like you said, one of the biggest barriers is application.
Yeah.
So when you have a patient in the office, do you have them show you, how they're putting it on or how they're taking it off? Or is that something where once you've talked to them about the garment itself, they're managing it on their own? Or is that something that you can?
I always wanna see them with it on from their house to see, A, if they're putting it on correctly,
Perfect.
and B,
Oh, that's really smart. I didn't think about that. Okay.
yeah, because sometimes even an ankle brace, just the other day, I saw a patient putting it on completely upside
Oh
down.
man.
So it's nice to just reiterate, the instruction on how to use the device, but also if they show up with it on, I'm more likely to believe that they're compliant with treatment versus, "Oh, I left it at home, but I'm
Mm,
not wearing it today." Well,
gotcha.
I'm not sure how many days a week you're actually wearing it. So,
Mm-hmm.
yes, I always want, if I prescribe a specific garment, brace, etc., I want them in my office with it on.
Right. And you just brought me to a really important thought here is that you're responsible for documenting their compliance. And so when they come in without the garment on, you're forced to go, well, they're not doing what I've asked for them to do. So if that condition continues to worsen or over time they need further treatment, it's unlikely that their insurance plan may cover it right away if they see that you've been documenting that they've not been compliant with their first line of treatment. So providing them with a garment that allows them to be more compliant is the first step to getting a patient to be more compliant.
Correct.
So I'm really glad that you brought that up. And that brings us to the most important piece, like I said, compliance. Because in reality, many patients don't stop wearing compression because they didn't want to. It's because it's difficult to put on, it's uncomfortable, or just maneuvering through that task on a daily basis just doesn't fit into their routine. So in fact, studies have shown that adherence to compression therapy can be as low as 30 to 50% in the patient population. And how does that translate into your daily practice when you see patients that just aren't complying to the treatment that you've offered them?
It's, hard to convince somebody to be compliant in order to prevent the end stage of something. um if it hasn't happened yet, it's hard, once a complication happens, then the patient's going to be more likely to be compliant. But for something theoretical that hasn't happened yet, sometimes it's hard to communicate that with the patient.
Yeah.
You just have to keep on trying. But when something is more user friendly for them to adhere to, it makes my life easier, it makes their life easier.
And that's really what we want to see is that testament in your office when you've got these patients coming in with a garment they can really be using. So I'm excited that we're talking about this today, and spreading the word because it's how comfortable and manageable the garment is for them. It's where adjustable compression wraps come in. Unlike stockings, the wraps are applied in sections and secured with closures instead of having to rely on that strict compression like the other sleeves and stockings do. The difference between stockings and wraps isn't just the material, like we said, it's the usability. From a clinical standpoint, how do you typically decide when a patient should move from what they're accustomed to, but may not be working for them,
Yeah.
into a wrap option?
So either the patient will say, I'm having difficulty applying this every day, or I see the progression of the disease in spite of the fact that they're using the compression. I have a patient right now actually that we're treating for cellulitis because the patient, and this is the first time I saw the patient, but for years prior to presenting to my office, the patient was using compression that was way too light for her lymphedema. And so she is at the point of that fibrotic, those nodules all over her leg, um, and extensive edema. So right now we're treating the cellulitis, we're doing the compression dressings in the office, and she is going to be converted to a wrap versus a stocking.
And that's another thing that I really like about the wraps too, is that it incorporates all of the MMHG doses because it focuses on containment as opposed to the stockings, which you're tied into that dosage. If you've said, hey, you need to go get a 20 to 30, well, that's what they're stuck with, much like your patient.
Yeah.
At some point, she probably needed a little bit more compression. And if she was in a wrap, she would have been able to adjust that much more quickly and much easier.
Right.
So while stockings provide consistent compression, they can be harder to manage. So it's definitely something that we make a point to address with the patients. And compression isn't just about the type, it's about the level, like we said. So the right modality and the right level of compression both matter depending on the patient. In more intensive phases of treatment, particularly early on, you mentioned bandaging can also be used under clinical guidance. And then you've got the pneumatic compression devices, often referred to as the pumps. And those use the air chambers to apply pressure and cycles along the limb. They're typically used at home, right?
Yeah.
For most patients, but not as a replacement for garments, just as something in addition to their current overall treatment. It's an enhancement rather. So typically these are considered for patients who have not had sufficient improvement with compression garment or conservative therapies. So at what point do you go, all right, you've had X amount of time using compression garments. I haven't seen much change. Let's get you in line with a pump.
Well, when basically we're not getting the edema down enough, or they're weeping or producing those bulla or wounds, we need to up the compression. And if they're using the appropriate, wrap or stocking with the appropriate millimeters of mercury compression strength, and it's still not enough, we need to add adjunct treatment via the pump.
So to me, it sounds like just from the few questions that we've gone over, progression is the main factor for moving a patient into the next line of
Yeah,
treatment.
exactly. Because there is somewhat of a protocol in choosing what is appropriate for the patient. If the patient has never attempted any kind of compression, we can't jump to a lymphedema pump.
Right.
There has to be a response or lack of response of one treatment in order to move on to the next treatment.
And sometimes you hear that patients will go on Amazon or some website of their own and they'll purchase an at-home pump and they come to see you and go, oh, I've been using this pump on my own, but they never did compression therapy. Is that something where you can tell them, hey, it's great that you started to advocate for yourself?
Yeah, but without the compression aspect of it, so you could use the pump for 30 minutes a day, but then what happens with the other 10 plus hours of the day? You need to have that consistent compression.
Exactly. And that's what we look at as a whole with compression therapy. It's not about just one option, but about matching the right approach for every patient. Like you said, in the early stages, garments are more appropriate. With more advanced stages is when we can talk about wraps, which may be more effective. And then, like you said, the pumps can be added in for additional support. So and that all comes back to one thing, which is realistically, what can a patient use every single day? And, a really common scenario we see is a patient that's been prescribed a garment. They get it, they try it on once. It looks cool, great, it worked for the day. After that, I'm cured in their mind, or it just didn't fit right. It didn't, they couldn't get it on properly on their own. And then it just ends up folded in a drawer somewhere. And then they show up to your follow-up visit and there has been no improvement with swelling. And so the goal becomes not just prescribing compression, but making sure it's something that the patient can actually incorporate into their daily routine. And this is where having the right support in place makes a big difference, because when patients are properly fitted, educated, and supported, compliance improves significantly. So from a practical standpoint, this doesn't have to be complicated. It's about identifying patients during their normal visits, having a process that helps move them forward without adding any unnecessary burden on both you, the provider in the office setting, and the patient. So there's a few different ways that we offer support. Some patients are referred out and everything is handled externally. And by that, I mean, maybe you might say, hey, go here to get this and let me know if you have any trouble. But there are some providers that are choosing to keep that model connected to their practice while the administrative side is managed. So that way the focus remains on patient care. And in those situations, there's product education, there's vendor support. So both the office staff and the patients feel confident with what they're being provided with. And beyond that, the only thing we can do is really spread awareness. So we're going to continue to provide education around lymphedema and compression therapy for both patients and providers, because awareness and understanding are the biggest part of improving outcomes. Mm-hmm. Especially for the patients that are listening, one thing I do want to mention is that prioritizing your health doesn't have an age limit. You're never too young, you're never too old to start taking steps towards managing your health more proactively. So the more comfortable the patients are with their treatment, the more confident both you as a physician and the patients feel with guiding them through that process. One thing I do want to touch on, because you did mention it, is the surgical aspect. Mm-hmm. And it's often overlooked is the post-surgical population. We see a lot of patients where swelling after surgery is assumed to be part of the normal healing process, but then that swelling lasts a little bit longer than expected, or it doesn't ever actually fully resolve. It may actually be developing into post-procedural complications or lymphatic issues. Yeah. And those patients often don't receive earlier preventative treatments because it's not being flagged. So, and I'm sure you've seen a lot of that too.
Absolutely. I've seen patients who thought that, 20 years after an ankle sprain, it was normal for that leg to continue to be swollen. Um, and those are the patients that you have to consider that diagnosis of lymphedema.
Wow. And that's the biggest thing, is that how often patients don't realize they're dealing with this. And they feel it, they know something's not right. They just haven't asked the right questions, or they haven't been connected to the next step yet. So at the end of the day, like you said, lymphedema is a chronic condition, but it's one that can be managed effectively with the best providers and with improved access and a better understanding and the right support in place. So we can close that gap, recognizing the condition and actually treating it. So I'm really happy that we had the opportunity to discuss this and kind of continue to spread the awareness.
Thank you.
Thank you.